Hello, everyone.
Yes, we are ready
Um,
to go, ma'am. Yes.
yeah. Uh, Hello, everyone. A good physician treats the disease, but the great physician is the one who treats the patient who has the disease. So, with this quote of Sir William Osler, I would like to wish all of you a very good evening. People, those who have joined, all the participants, a very warm welcome to all of you in second international webinar series, which is being conducted by Biotech Department of IMS Engineering College. So we started with a few days earlier, last month, we started with the first international webinar series, and we conducted 3 lectures in it. And this is going to be the first lecture in our second international webinar series. The speaker for today is Dr. Divisha Sharma, who is a resident doctor at Manatee Memorial Hospital in Florida. I welcome you all. I am Shomini Parashar from the Department of Biotechnology at IMS Engineering College, Ghaziabad. And on behalf of the entire department, I extend my warm wishes to Dr. Divisha Sharma and all the participants, very inquisitive participants of today's webinar. Dear all, the topic for today's webinar is the application of technology in medicine for solving global health problems which we are facing currently. Dear all, the Department of Biotechnology at IMS Engineering College was established in the year 2002 with the undergraduate engineering program in biotechnology. In 2002, AMTech course was introduced to cater the higher educational requirement of the students. And since then, the department has been actively engaged in various research activities, whether we talk about the projects that we have undergone in biotechnology division and related fields. We have got several projects like UP pollution control project and a project related to the vaccine development of, you can say, malaria. And since then, our department is actively engaged in various kinds of research activities. We are also a research center, authorized research center of PhD from AKTU, Abdul Kalam Technical University, Lucknow. Our department is NBA accredited and our college is grade A NAC accredited. And we provide 92% placement to our BTech students since last several years. We are proud to say that we have been successfully conducting these webinar series, and there are many aspiring participants every time we conduct the series. So there are instructions which I have also given to you earlier, like if you have any questions during the webinar, there is a window, a chat window. You can write your questions in the chat window, which will be taken at the end of after the end of the webinar. Another thing that I would like to tell that if you share your screen, it is going to spoil the presentation. So please don't share your screen and don't show the video. Keep it off, keep the audio off. We will send you all the relevant links and e-certificate of participation after the event, including recording of your registered email ID. So we have your registered email ID. We will send you all the links and everything that you require after the webinar is over. So with this instruction, I would just like to tell you that God cannot be, because God cannot be everywhere. So he created and he sent doctors with excellence and selflessness. In the current COVID scenario, it is a great job that all the doctors are doing across the globe. And we are privileged to have one such very young and aspiring doctor among us, Dr. Divisha Sharma. She did her MD in medicine and she has been practicing in Florida since last 3 years. And I'm really thankful to Dr. Divisha for sparing her valuable time for the webinar. Thank you very much for joining. And now I would like to ask Divisha Sharma to please take over the screen and proceed with the presentation. Thank you very much. And now over to Dr. Divisha Sharma.
Thank you, Shomini ma'am, for such a wonderful introduction. And I would like to start by thanking IMS Engineering College, Ghaziabad, for organizing the webinar series and for inviting me and giving me this opportunity so that I could reach out to so many students. Thank you, everybody who's participating today, for being here and taking up the time. I hope all of you had a great day. Let me know if you all can you see my screen?
Yeah.
Okay, great.
We can hear you and see your screen.
Wonderful. So the topic for today, as discussed, was application of biotechnology. And I think this is one of the best times to live in the world because technology is the best that it can ever be since as compared to yesterday. And as compared to tomorrow, we're most motivational since ever. So let's see what are our current health issues. They're mostly the same, but I would like to divide them into issues between developing countries and between developed countries. So developing countries, we start with malnutrition because they're usually demand supply mismatch, underdiagnosed or undertreated, especially vitamin B12, vitamin D, calcium, iron, and folate deficiencies. Then we also have infectious diseases, which are more prevalent in developing countries. And the reason is that it roots from lack of education, which is from poverty, overpopulation, and pollution. And that has been a challenge for developing countries to fight for a really long time. Developed countries, on the other hand, their most important health problems are metabolic syndromes. These metabolic syndromes include obesity, hypertension, hyperlipidemia, coronary artery disease, cardiovascular accidents or cerebrovascular accidents, diabetes mellitus, and pulmonary hypertension. And the reason is there is a trend of Coca-Colaization and burgerization, as one of my professors used to say. Everybody's eating fast food, forgetting their authentic food, and the culture in a way promotes them to go towards obesity, which is the cause of all metabolic syndromes. Substance abuse somehow happens to be on the top list of developed countries. These actually make a substantial proportion of emergency department visits in United States. I see every day how the population, especially the younger one, has been affected by the opioid epidemic and alcohol and various other street drugs. Third will be cancer. That will be because the population is living longer. We're diagnosing it much quicker. We have really advanced screening tests. We catch it earlier, but also we are treating it for a longer time. What are everybody's problems? No matter if you're a developed country or an underdeveloped country. There are problems that everybody's talking about. It's COVID-19. And then there are problems which nobody talks about, mental health, which is extremely important, especially in today's day and age, when everybody's locked down in their houses with their loved ones. And then, as they say, more utensils in the kitchen, the more sound it makes. So I feel mental health is something that everybody should come out about. Let's talk straight up about COVID-19. I think that is something everybody is eager to know. And a lot of scientists have been working hard day and night trying to figure out a cure for all of us. So let's take a break here. Let me talk a little bit about my past experiences since the past few months. So I work at a hospital in Florida, and I'm working as a resident physician. So I'm still working under a few attendings. And I was posted in the ICU for a few weeks during the first peak of the pandemic. And the families were not able to come in the hospital to see their loved ones because we had security issues. So we would FaceTime the family members to say the last goodbye to the patient who was dying. And I think after doing it for 15, 20 days, it started to hit me that it's not very far away. Death is right here, right in front of us. And no matter what we did, we could not make peace with the deaths. But then somehow I realized we have so much technology. Somewhere, somebody is still working day and night to figure out what's going on. And I'm really thankful to everybody. So to talk about the virus, it is a positive sense, single-stranded RNA virus with a single linear RNA segment. And this is the structure of the coronavirus. Most of us understand what a positive sense single-stranded RNA is and how is it different from other RNAs. So about the clinical presentations that we've been seeing, the most important one somehow happens to be pneumonia that we have to struggle with. And what it causes is, it causes bilateral diffuse ground glass opacities and dense infiltrates, as we can see here. These infiltrates make it very difficult for them to breathe, and their oxygen demand rises because all tissues basically need oxygen for them to function. And once the heart also meets that demand, goes up, it starts to work harder, and people can go into cardiac arrest or pulmonary arrest, also together known as cardiopulmonary arrest. Also, one thing that has been noted in COVID-19 patients is that they're very coagulopathic. That means that they form large amounts of blood clots. Not only that gives them to have a heart attack, but they're also more susceptible than the rest of the population to have a stroke or a deep vein thrombosis or a pulmonary embolism. When they start, and we start to know that they're not just breathing on room air, they need supplemental oxygen, they first go to oxygen with nasal cannula. Then before trying invasive ventilation, we want to try non-invasive ventilation or NIV. Let me show you a picture of one of those. This is a CPAP machine. This is a little more oxygen with a little more pressure. The problem with this is that we are at risk of aerosolization of the virus. So we try not using this method because as you see in these lines, there is no way to put in a filter to stop what the patient is breathing out to come out filtered. So then we go to intubation or life support, which puts most of the healthcare workers at risk. But we still have to do this because that is the only way for us to help them breathe. How we do that is on this side, you can see how we put an endotracheal tube in directly, which goes into the trachea, and then it can go to their lungs. And then over here, we attach the machine, which is this ventilator machine presented here. So this, to keep the patient on a machine like this, you have to sedate the patient. So they're totally knocked out at most of the time so that they're not agitated and not trying to breathe over the machine. And in the meanwhile, the machine gives them oxygenation that we fine-tune it to at a level that we find it to and at a pressure that it needs to, because the pressure in the machine and the oxygen flow needs to overcome the pressure in their lungs. And when there is so much dense infiltrates, the pressure is increased. We also have to find a fine balance between the pressure we give and the pressure at which the lungs can be damaged. So it is a constant battle bedside at all times. And either a respiratory therapist or nurse or a doctor, especially a pulmonologist or intensive care doctor or internal medicine doctor like me, are present bedside making those changes. Finally, we have some new technology, which is called Ecmo. It is known as extracorporeal membrane oxygenation, which we use for patients that are not even improving on a machine. So this is what it looks like. It is a massive setup. It requires at least 2 to 3 specialists in-house at all times. This machine, as the name can suggest to you, helps to take off the load from the cardiopulmonary in the body. So the oxygenation happens outside the body.
PPTs are not visible. PPTs are not visible.
Oh, really?
Yes, yes.
Somebody else sharing their screen?
Your screens is not sharing. We are just looking.
Sir,
No,
PPT is visible. Please look for Divisha Sharma presenting screen and pin that. The list of participants, look for Divisha
and all the
Sharma presenting
participants,
screen.
yeah, for all the participants, because I'm able to see that.
And please continue. Yeah,
Just click below present now.
yeah.
Can everybody see my screen?
Yes, it's visible, ma'am. You can continue.
No,
Okay.
not at all. No, not at all.
Sir,
Go to
please
Divisha Sharma's
go to
presentation.
Divisha Sharma presenting screen ID and pin that. In list of participants, you can search it.
Nobody is able to visualize the PPTs.
See, you have to go to the presenter ID where it is written, right? And then there is an icon pin. You have to click on that in the presentation. Look for the second ID and
Yeah,
pin it.
there are two IDs with the same name, Divisha Sharma. Just try either.
Click below the right side below present now.
Yes, now I hope everyone can see.
Now it is all right.
Yeah.
Thank you, Ma'am Divisa.
Sorry.
Fine, Divisha. Please, ma'am,
Thank
you
you.
can continue.
So as I was talking about non-invasive ventilation, invasive ventilation, and then the newer technology that we have that helps to have ventilation outside the body. So whatever our lungs and our heart is doing, it can actually be mimicked to do outside the body, but then the process is very crucial because the blood can clot in all these tubes, and then you can only do it for so long. Only very few facilities have availability of such extensive management. This reminds me of a story that I want to share with you all. So 2 months ago, I had a really young patient, around 32-year-old female, post-cesarean section. She comes in with a shortness of breath. So she undergoes cesarean section. She's intubated, so she already has an intact airway. She is not able to be taken off of the ventilation because her oxygen requirement continues to be high even after the surgery. She's sent to the ICU to us to be monitored. We get a CT scan, and especially getting a CT scan in a patient who has already this setup inside them is a challenge in itself. We see in her lungs that they look exactly textbook like this. So we try to treat her, we try to intubate her, we consult infectious disease, we get every way to get her out of this process because she's really young and we don't want to lose her and we don't want to lose any patient. So finally, when we are out of all medical modalities, we transfer her to Tampa General Hospital, which accepts our patient and puts her on this machine for a few days. After a few days, I see her walking down the hallway holding her few days old baby. She came to thank us. So that was an experience. So technology actually saves lives. This is from the registry of Ecmo that I saw a week ago when I was preparing this presentation. This is just the census of how many people are on the machine with suspected or confirmed cases and how many were discharged alive and how many are still on it. So as you can see that even in each state in the United States, very few facilities have this technology, and still there are so many patients who are still waiting to be discharged alive or unfortunately not. So let's talk about the medication that we are using these days. remdesivir. It is an investigational antiviral agent under evaluation for COVID-19. So the United States has granted an emergency use authorization to be used in severely ill hospitalized patients, especially the patients who have oxygen requirements, and we know that they can go down south, that they have other comorbidities, and it will be difficult for them to breathe by themselves on room air, and we feel like they're progressively worsening. We start them on the medication after getting approved by infectious disease. So this medication, there was actually a preliminary report of a multinational trial of around 1,000 patients with confirmed COVID-19 and pulmonary involvement, and remdesivir resulted in faster time to recovery and trend toward lower mortality, but it was not significantly, it's statistically significant. But United States Food Drug Authorization still granted an emergency use because it is in the situation of a pandemic, and when we have nothing else to use, I think something is better than nothing. Randomized trial in China of 237 patients with remdesivir versus placebo showed similar results as well. So the mechanism of action is that it inhibits the RNA-dependent RNA polymerase, preventing viral replication. So I like the way that currently everybody in a situation where there's so many viral diseases that we use the similar mechanism of action, it came in handy here as well. This is just to discuss how it works and where it works. So you see where for the proteolysis, some of the antiretroviral medications work. Some take away the translation and RNA replication phase. This is where they were thinking that hydroxychloroquine and chloroquine was showing mortality benefits in post-exposure prophylaxis, but it does not. And this is just showing the progression of this. So remdesivir is expected to work over the RNA-dependent RNA polymerase. What is convalescent plasma? This is another modality that we are using in our patients who we feel that will perform better in their functionality if we do something rather than we wait and watch. So this is plasma from individuals who have recovered from COVID-19 and may provide clinical benefit to patients with active COVID-19 when given early in the course of disease. So if we wait and watch, things go south, nothing's getting better, and as a last modality, it'll be very difficult to use this. It should be used a little earlier in the course of disease because it helps us develop those antibodies from the passive immunity. It's still unknown if people who have already recovered from COVID-19, how long their immunity lasts for, and if they are still susceptible for reinfection. The confirmation of it has still not come from the CDC or WHO, so we're still working on that. So vaccines. Vaccines worldwide, I feel, is one of the biggest endorsements of biotechnology. It is one of the largest help that biotechnology gives us for pre-exposure to any disease. For example, hepatitis B vaccines when a baby is born, or vaccines against all the infectious diseases that we have. It is almost the same concept. Numerous vaccines are being evaluated for precision currently. They all have very different mechanism of actions, but all towards the same goal. Some are nucleic acid based, like mRNA and DNA vaccines. Some are viral vector vaccines. Some are inactivated or recombinant protein vaccines. They vary in their potential safety, immunogenicity, and speed and cost of manufacturing. And that is how they will also be different in coming out in different parts of the world, because the requirements in different parts of the world will also be different. Secondary to, of course, their cost and also how easily they're available. I was looking yesterday at this page from WHO, which shows that they had a draft for COVID-19 candidate vaccines, and this is from yesterday. I see that the only one here in a phase 3 is the one from the University of Oxford. I believe that I'm not sure how easily this one will be available, but it's looking a little promising to me. So as we know, phase 3 is effectiveness in clinical practice. So this is where this is. These are phase 1 and 2. Phase 1 means that the vaccine is being designed to test safety, side effects, best dose and formulation. So they're getting there, but not really. And most of the vaccines that I saw, other than just this, they were like a 7-page of vaccines that are still in preclinical trials. So there's a lot of people all over the world working on a lot of things for us. So common things being common, I have always been fascinated with the most important medical conditions other than just the pulmonary involvement of COVID-19. We have the acute coronary syndrome, which is also a presentation of COVID-19. But not just COVID-19, in also reality, this is one of the most deadly diseases that we can cure if the patient presents to us early, with symptoms that can be recognized from door to balloon time of 90 minutes. That means that when the patient presents to us at the door, or when we know that there is a patient who could possibly having a heart attack, we start preparing a protocol to make sure that the patient reaches a cardiac catheterization table and there is a balloon put in his heart to open that blood vessel within 90 minutes. And that has shown so much success that it is a part of the protocol that each doctor follows. I just wanted to teach everybody a little bit about acute coronary syndrome, as it is one of my favorite topics, but also that the hospital that I work at is a cardiovascular institute. So I feel like I am very well trained to talk about this. So acute coronary symptoms, chest pain. So you see how this guy looks really uncomfortable. His hand is on his chest. He feels like something is sitting on his chest. He can't breathe. He looks uncomfortable. The pain can go to the arms, shoulders, neck, jaw, back, and upper abdomen. Along with this, you can feel short of breath, cool and clammy, nausea, lightheadedness. What really happens is there's usually a blood clot sitting in the heart blood vessel, and then it suddenly blocks it. It blocks the oxygenation and the nutrients to the muscle, to the area of the heart. And once
it's 9 o'clock.
So sorry about that. Once this area dies, that is a problem. 90 minutes, because it has shown that we can still save the area and it will be still somewhat salvageable if we do it within 90 minutes. Let's see what the technology offers us. These are stents. These are really tiny. As you can see, it can sit on a fingertip like that. What does it do? It just goes there mechanically, sits there in the blood vessel and helps prevent the blood vessel from getting blocked. It helps a good flow of blood flow towards from the coronary arteries to the muscles to supply. The various types of stents, and I feel technology did great here. They're drug-eluting, bare metal, bioreabsorbable. Let's talk a little bit about them. So each stent consists of 3 parts. It has a platform, a polymer that binds the polymer coating that binds the drug to it, and then the drug itself. The drug is released slowly. It's like an extended release form of drug release. And then the stent platform itself it's an expandable framework generally with an elaborate mesh-like design to allow expansion and flexibility. So these are the 2 most common ones as we were talking about. So this is how we put them in a blood vessel. Once they enter the blood vessel, we can expand them like this or this. This is a bare metal stent. This does not have the medication in it usually. And then this one is a drug-eluting stent. There's a drug in it that helps slow release into the blood vessels. And it usually contains medication like everolimus or zortalimus or sirolimus or paclitaxel. Initially, they were made with stainless alloys composed of iron, nickel, chromium, and were based on an existing bare metal stent. But now they made new alloys, namely cobalt chrome and platinum chrome, to improve performance. So there were special alloys made just so that they can be placed in coronary arteries to help people save lives. This is how it looks like when it is being put in a blood vessel. So there is also a newer form of drugs, newer form of stents, which have been developed, and these are known as bioreabsorbable stents. They absorb over time and dissolve itself so that there is no stent left there for later to get stenosed or to get clotting upon it. It's also a foreign body, so the longer it stays in the body, the longer it will cause irritation in the blood vessel too. Every effect has a side effect. These are made from materials that include magnesium, polylactic acid, polycarbonate polymers, and salicylic acid polymers. And then there's another types of stents which are not really in clinical practice as yet, very popularly, but they are polymer-free stents. So they will be just a framework, and they will not need the polymer to attach a drug onto. So the lesser the material, the lesser the inflammation, and the lesser the risk. With this, I would like to talk about how thankful I am to be able to be with everybody, to be alive. I'm really grateful. I would like to pray for the soldiers who are fighting on the border for us, all the doctors and the healthcare staff at work right now, and even at home who are self-quarantined or who are locked down like my parents, and everybody else in all over the world who are going through a lot of mental and also physical discomfort because of the pandemic. Patience is something that we all need to work on every day, including myself, in these hard times, and how it is important to not just be kind to everybody else around us, but also to be kind to ourselves right now. Take it easy, and everybody is going through something. Some goals, some vacations have been put on hold, but I think if we all as a community stick together, but also distance ourselves, we might still be able to survive this second wave. There is a second wave of COVID-19 coming, which is almost at its peak. And all I would like to say is everybody stay safe, wear masks, wash your hands, and if you can hug your loved ones at home, just give them a big hug, because you never know when hugs are going to go out of fashion. Thank you for having me. I'll be taking questions now.
Thank you very much, Dr. Sharma, for such a wonderful and informative presentation. It's a pleasure to have you here for the webinar, and the session is open for questions. Let me see what all questions we have in the chat window. We'll be taking questions one by one. If you have any question, you can write in the chat window and that will be taken. See, I have already told you that we are going to mail you all the the links of the presentation and everything once the webinar is open. That is fine. For questions, I'm searching for questions in the chat window. I think if you are able to see Divisha, please, you can find out.
Okay.
Yeah, there is one question I could see from Sedhu Bharat. Please, Rahul, please stop video. Turn off your video, Rahul, Mamta, and all everybody. So the question is the vaccine now finding is helpful if SARS continues to mutate? So if SARS continue to mutate, so whatever vaccines we are finding, is it useful? I think he wants to ask this.
Very good question. Actually, so we know about viruses that have shifts in them or drifts in them. So this is a mutation that a virus can cause and can cause different types of strains within itself. The most common one that we know about is the influenza virus, also known as the common cold. Each year, we get a new vaccine for influenza for each season because the virus itself changes really drastically, which is also known as the drift. It's a dynamic change. For that, we've been finding different vaccines each year. We don't know yet what is the capacity of coronavirus to cause a drift or a shift. For now, these information has not been released, but we don't even have a vaccine right now in clinical practice out of the clinical phases or in the post-marketing surveillance phase to know how it works on the present strain that we have. Maybe in the future, the way it mutates, we will have to find out newer vaccines, just like the influenza, and then people will have to go every season and get a new vaccine whenever it's out. The seasons for influenza vaccine that I tell everybody to get it is around October. When the newer strains are out, go and get the newest vaccine each year. You can take it nasally, you can take it intramuscularly. Maybe we will be living in a world where we will be going and taking vaccine for coronavirus every season as well.
Right, maybe. Is there is another question from Priya Yalini. Is there any solution to stop spreading COVID-19?
Yes, we do not have a lot of tools in our hand, but the biggest tool that we have is to wear masks and socially distance. It is because we know that the virus aerosolizes. We know that it can be present in the air, but it's also very notorious to be known to live on the surfaces. It can stay on cloth, on plastic, on even metal. And it has different times of staying alive on different surfaces. So if we just practice good hygiene, like washing our hands, but also cleaning all the surfaces, and we know that it can be killed by disinfectants, which has more than 70% alcohol by volume. Wearing masks and distancing from anybody who you think can have it, or you can give it to them. Always think yourself as a vector. Always think that maybe I have it. And if you really care about the world around you, do not give it to anybody else. You should wear a mask and not go close to anybody. These days, we don't do handshakes. I do not go to a patient room and say, "Hi, I'm Dr. Sharma." I give them an elbow. I don't want to touch them. And they understand, so they give me an elbow too. I always wear a mask, but I always tell them, I'm wearing a smile on my badge, and I just want to let you know that I know you're very sick. I care about you. I know you cannot see my smile behind my mask, but I'm smiling for you. So, just a little bit of kindness maybe, but also a lot of hygiene practices at this time, which will take us a long way.
Thank you. Another question we have is Wakas Khan. What is Coviper? I read it, but didn't get what it is.
Coviper?
Coviper.
Is it like, I'm not really sure. Is it one of the vaccines coming out? People give different names to different vaccines. I'm not sure. I'm not sure of the generic name, to be honest.
Okay, let us see another question if I could find. Okay, metformin is supposed to help in treatment. What are your views? It is a question asked by Siva Subramanian V.
Hi, yes, metformin is actually one of my favorite medications to treat a lot of different medical problems, but it was initially came in clinical practice to be used in patients with type 2 diabetes mellitus, which is diabetes secondary to aging, obesity. Some of the people are predisposed to it. And one of the first medications, if there are no contraindications to it, is metformin. And then we slowly go up on the disease dose, on the medication dose, if there are no side effects. Every medication has its side effects. I like metformin also because it is one of the only medications that are commonly used that do not cause hypoglycemia. That means If you give it to somebody with diabetes, it is not suddenly going to drop down your blood sugar and you're not going to pass out. I also like to use it in pre-diabetic patients who are predisposed to having diabetes in the near future. Obese patients with any abnormal lab markers, and also patients with PCOD or PCOS, we use metformin to reduce the insulin resistance. What happens is the more mass you have, which is adipose and fat, the more insulin resistance you can build up. Your pancreas can get tired of making so much insulin for all the mass that you have. And because of that exhaustion, you can have diabetes. So I think metformin really helps reduce that level of resistance.
Right. That's great. Another question I'm able to see here is from Omkar Kadam. How the stent is removed after the patient is treated with the drug through the stent? So I think that has been already told, but you can repeat.
The stent remains in. The stent can remain in for as long as you're alive. But it's important to get frequent checkups because everything comes with an expiry date. So after 5 to 10 years, if you start having the symptoms again, that means that the stent is being clotted and the medication has been used up. And now it is just a foreign body sitting there. You should go to your doctor and get evaluated.
Yeah, another question from Dr. Tanya Sen Gupta. Is vaccine possible for the RNA virus having no proofreading mechanism during their application?
I'm unsure. Unsure.
Yeah, another question is Vidhi Gupta. How the second wave of COVID-19 is going to be different from the present scenario?
Very good question. So it's not far away. It's right here. We are actually living in the second wave. So what really happened was when the first wave came in, the first people to get infected were the older people, and they all died. So what happened is that this newer wave that's coming in, we could be a little more prepared right now because we have more supplies, more PPEs, more masks. The first wave, we were fighting there like warriors without a single weapon. I remember actually tying a cloth around my face, going to the hospital and begging people to give me masks to wear and just wearing plastic glasses or whatever I could find to protect myself. Second wave, I have more PPEs, but younger population is affected. Between the first wave and the second wave, people started feeling, oh, I think it's going away. People started going out, the beaches started opening, some stores started opening, and I think a lot of people got infected during that time. So this wave, I'm seeing younger people having higher oxygen requirements, but still better prognosis than the first wave. I think that's something to do with the age.
Right. There is another question from Chandan Mohanty. I have a question that how we will be safe from non-symptomatic patients.
I don't know. I think what we can do is we can just think that I'm asymptomatic, but maybe I have it too, and then just wear a mask. So I personally myself did not get tested, but I think that I have seen at least 100 patients myself with COVID-19 positive, and I do not want to infect anybody else. So I do not go and meet people who I can make fall sick. So I always maintain distance and I always wear something. But no matter if somebody is asymptomatic or have very mild symptoms, they could be highly infectious. You never know. Just be careful.
Right. Another question from Dr. Divya Bhadoria. Is hypertensive patient on risk in present condition?
That is true, yes. Because hypertension is a silent killer, as we all know. And untreated hypertension means that patient has cardiac disease because their heart has been going to the gym every day, trying to push all that high blood pressure. So they already have predisposed cardiac disease. They have predisposed chronic kidney disease because of their hypertension. They're possibly also obese, and obesity is linked to hypoventilation of the lungs. All obese people, because their abdomen is right up where the lung is, and it's usually pressing on the diaphragm. Those patients at baseline, I think, are undiagnosed hypoventilated. And when they get infected and they have thicker infiltrates, their oxygen requirements are difficult to bring down. So hypertension is a risk factor, and I would say take your medications, keep blood pressure controlled, exercise, weight loss. If you lose 10 pounds, your blood pressure goes down significantly, and you can be off of medications, but it depends why you have hypertension. If it's essential hypertension, weight loss, salt restriction, diet, follow the DASH diet, lose weight, and then maybe you will be able to fix all other comorbidities, and then you will be ready.
Right. So another question, can herd immunity be a decision for COVID-19?
We are not aware of any review that has come out of it. And also the risk factor of developing a herd immunity is so much, because this is not just something that people are developing through each other, having a small episode of sickness and then recovering. We're talking about a pandemic which is taking lives. So we're not sure how to expose people to develop herd immunity. I'm not sure if in any other part of the world they're working on developing something like this, but currently WHO and CDC guidelines, they all say socially distancing is the only tool that we have in our hand right now.
Now, Naisargi said, asked a question like, if any vaccine comes, how long it might take to control this pandemic?
Pre-exposure prophylaxis, right? Vaccine is something that we take before the exposure. But how fast will that vaccine develop immunity in a patient depends on the patient who receives the vaccine and also the mechanism of action of the vaccine. So if they will recommend us to get the vaccine and then stay in our houses to develop immunity, it will be their decision. But another thing is, how will they give the vaccine? I don't know. Will they have a chit system that everybody who gets this chit, or a lottery system, come out, get the vaccine, or people who are the sickest most get the vaccine, because that will be scary too. They might have some side effects and reactions. It is all unknown currently.
Well, right, ma'am. There is a question like, which mask is effective for this condition?
So they say that N95 that we have always been using for tuberculosis, which is one of the other most common aerosolized conditions that we have in our countries, or anything above N95. The filter name is N95. You can use N99, you can use anything better. That is for close contact. But if you have nothing else, and if you know you're gonna distance yourself, a cloth mask. I usually, when I go do groceries, I just wear a cloth mask or a surgical mask that's easily available at any pharmacy, at any doctor's office. Make one at home, use your sock. There are like so many DIY videos. Cut a hole in your sock, put it in your ears, and just wear it. Anything that covers your oral secretions, that'll be good. And socially distancing will make sure that your airway secretions do not reach the other person.
Okay, there is one interesting question I'm able to see from Shweta Tiwari, I think. If any patient has recovered from COVID-19, what is it? Repeat again, the same patient. What is it? Repeat again in the same patient. Oh, Mati, fine.
I do not know if it can happen again or not, but every time I discharge a patient who was COVID-19 positive, had symptoms, and then we retested them to be COVID-19 negative and discharge them home, I do not tell them to go out and mingle and get sick again. I tell them always, I do not know if you can have this infection again or not. I do not know what can happen. I do not want to misinform anybody. So I always tell them, just stay inside and try not to get reinfected again, because maybe the second time you fall sick, we might not be able to save you.
Well, there is last question of the session, and there is the question is asked by Vinod Kumar, artificial RBC transfusion therapy can possible for immediately treating hypoxia in COVID-19?
So I think your question comes from the idea that you think that oxygen is getting carried in red blood cells. Actually, hemoglobin gets bound to oxygen, but hypoxia is not treated that way. For hypoxia to be treated, the process is the same. When there is an ECMO machine, extracorporeal, you give oxygenation, but you also have to make sure that the blood that is already in the body that has produced carbon dioxide and lactic acids and other toxins that it's taken from other parts of the body is also removed. So just giving oxygenated red blood cells, which is basically theoretically and practically not possible, it is also important to remove the carbon dioxide and the lactic acid and the other waste materials that have been produced by the cells and is in our venous system. Also, just giving more volume is not practical. The patient can go into hypervolemia, can have pleural effusions, will be fluid overloaded. Good to think about, but not practical.
Okay. So I hope all the questions are done. In SARS, MARS, and COVID-19, spike glycoprotein is same. Is it same? It means he wants to ask a question. If it is same, then, oh, what happened? The question moved on. If it is same, then what is the possibility to develop a multimeric vaccine?
I think that's what they're working on. They're trying to figure out similar viruses that also all belong to the SARS-CoV family. And then they're trying to see how the similar structures and the similar family group and the similar virus synthesis can help in making them the vaccine. I think that is the core process that they're working on, but I'm unsure if they're specifically looking at that one.
Okay, can CRISPR be used to treat COVID-19?
What's CRISPR?
CRISPR technique?
I'm unsure.
There's a question.
Whatever this technique is, I'm not using it.
Well, I suppose people are working on this also. So many questions have been taken, and thank you very much, Dr. Divisha Sharma, for answering all the questions and being so patiently answering all the questions. Thank you very much for sparing your time. And now it's time to ask our HOD, Dr. Rashmi Chandra, to give vote of thanks from our department side.
Thank you, Shomani. Very, very good evening to all of you. I, on behalf of Biotechnology Department of IMS Engineering College, extend a very hearty vote of thanks to Dr. Divisha Sharma for delivering a wonderful talk on application of biotechnology in medicine, solving current global health problems. I am very much Visa to gracing us with your presence and taking out your valuable time. I appreciate the delegates from different countries, students, professors, and faculty for their participation. Also, I would like to extend my special thanks to Mr. Priyaranjan Kumar and Ms. Shomani Parasar for arranging such an informative lecture. As no program can become successful with single person, so I extend my big thanks to our whole department, including our bright students and each and every faculty members for their support. Thanks for making this talk a successful event. Thank you so much, everyone. Take care. Thank you.
Thank you, Divisha.
Thank you so much, ma'am.